Welcome. My name's Jennifer Roeder. I'm a communications consultant for APFED, and I'm moderating today's webinar about eosinophilic fasciitis. Joining us today is Dr. Catherine Sims. She's a rheumatologist at Duke University and a health services research fellow at Durham Veterans Affairs Hospital. Her research initiatives and clinical practice focus on vasculitis and reproductive health. Thank you for joining us today.
Thank you, Jennifer.
You're
I am
welcome.
going to go ahead and share my screen. All right, good afternoon, everyone. Like Jennifer said, I'm Dr. Sims. I am a rheumatologist, and today we're going to really talk about eosinophilic fasciitis, or EF 101, just kind of going through the disease process, how to get diagnosed, what the treatment options are, and some of the challenges that patients with EF can face on a daily basis. So we'll start off first with a diagnostic process, then move into the treatments, and then finish up with challenges. So, what is eosinophilic fasciitis? And that is a mouthful for a lot of people, even for providers, and a lot of medical professionals have never seen EF before. So, I thought we could break down the term eosinophilic and fasciitis just to give everybody an idea of why this is named what it is and what cells are driving the autoimmune process that us as rheumatologists are trying to manage. And when I use the term autoimmune, what I mean is that your body's immune system is overly activated and it's therefore attacking itself. And as rheumatologists, our goal is to really decrease that overactivity of the immune system. And we'll kind of get into that a little bit later. So, I wanted to start off with where all of our white, red, and platelet cells come from. So, the bone marrow, which is present in all bones, but really is really active in some of those long bones. If you think of like in your upper arm or in your upper leg under your thigh, you have really long bones that are filled with bone marrow. And those produce white blood cells, red blood cells, and platelets. So at the bottom here, I have red blood cells, which is hemoglobin, and platelets. So these play a role in transferring oxygen throughout the body or clotting in the case of platelets. But we're really going to focus on white blood cells today. And when you've had blood work done in the past, you may have noticed that there's a breakdown of white blood cells, hemoglobin or red blood cells, and platelets. So we're focusing on that first category of white blood cells. And there's different types of white blood cells, but what we're going to focus on today is the myeloid stem cell. So stem cells are cells that are newly released from the bone marrow and they are trying to develop into their final version. And they can really develop into a lot of different types of cells. But the cells that we're going to focus on today are eosinophils. So eosinophils are a type of white blood cell. And in the average person, eosinophils are typically absent or present in very, very low numbers. So whenever a medical professional sees an elevation in the eosinophils, which medically is called eosinophilia, we're always kind of wondering, I wonder what's driving that process of the elevated eosinophils. And it's different for every patient, but many of you who have been through that process of getting diagnosed with an eosinophilic disorder understand that you see a lot of different specialists because when we first meet a patient with elevated eosinophils, we have this big list of diseases that could be causing the eosinophils to be elevated, and we really have to narrow that down through a bunch of tests and biopsies and imaging studies. So eosinophils can be elevated due to autoimmune inflammation, infections, things like parasites. Cancer can sometimes cause elevated eosinophils, and sometimes that elevation in eosinophils can be our first indicator that there's something wrong. And then something like allergies, like asthma or eczema, can also lead to an elevation of these eosinophils. So they can sometimes drive a more of an allergic reaction, but they can certainly also be playing a role in cancer, parasitic infections, and also autoimmune diseases. So going even further into what happens. So you have a stem cell that then becomes an eosinophil, a type of white blood cell. Then what does it do from there? So in the case of eosinophilic fasciitis, the eosinophils are starting to infiltrate the lining of the muscle, which is called the fascia. So if you think of muscle as like a piece of meat and then a saran wrap around the muscle itself. So this is like a spider web, very thin wrapping, and it kind of keeps the muscle in place and kind of siphoned off from other areas of the muscle. That's why you have like biceps and triceps. Each muscle group has its own little packaging around it. So this is called the fascia. And I have a picture here just to show you how thin this material is. And whenever there's inflammation of the fascia, we call this fasciitis. So that's really where the term eosinophilic fasciitis comes from. So once the eosinophils infiltrate or go into the lining of the muscle or the fascia, inflammation starts to occur. So the body doesn't really understand what's happening, but they knew that something is invading the lining of the muscles, and this just causes this mushroom of inflammation to start occurring. So inflammation can look like swelling, pain, heat. And then long term inflammation can lead to thickening of the tissue or fibrosis, which is irreversible damage. So, a question I often get is, why did I develop eosinophilic fasciitis? And the short answer is, we don't know why some people develop an autoimmune disease over another person. And what's also complicated is all autoimmune diseases are different. So, the reason that a young woman may develop lupus is different from the reason why a man in his 50s may develop eosinophilic fasciitis. So typically, a rheumatologist will give the answer, we think it's an interaction between your genetics and the environment that you live in. And it's an unsatisfying answer. And it's just because we really don't have great answers as to why some people develop a certain type of autoimmune disease and others don't. But in the case of eosinophilic fasciitis, we do have a few causes that we have pinned down in certain cases. So this is not for everybody, but sometimes really strenuous exercise. So things like running marathons or going from a sedentary lifestyle to like a super, super active, things like running a lot or hiking several miles. Sometimes that can be an instigator for that inflammation to kick off. We've also seen that as cancer therapy has become so advanced, and we have seen just miraculous recoveries in patients with things like lung cancer, they're being treated with cancer drugs called immune checkpoint inhibitors. And so those drugs are impacting the immune system. And sometimes the side effect is that patients will develop an autoimmune condition. And so that's where a rheumatologist comes into play. And this has become such a common phenomenon that we have rheumatologists who now specialize in cancer and work with the cancer doctors to control the cancer, but then also treat the autoimmune disease that's occurring. Sometimes cancer itself can be a cause of EF or elevated eosinophils in the blood. And then lastly, toxic oils. And this is less common, but whenever I see a patient who has elevated eosinophils, I ask them what kind of hobbies they have, what kind of work that they do, because exposures to toxic chemicals is certainly something that we should be investigating as to why the immune system is becoming unregulated. And then the patient is now developing an autoimmune condition like eosinophilic fasciitis. So, what does EF look like? And EF looks different in every patient, but there are some textbook, quote unquote, classic presentations that we learn about in medical training. So, the picture on the right is from a patient's online blog called My Journey with EF. And it might be helpful to just kind of see what her experiences have been like. This is a picture of her upper leg in the gym. And you can kind of notice there's a rippling effect on the top of the skin. And if you think back to that picture of the muscle with the fascia, if there's inflammation and then scar tissue that's forming from long term inflammation, you can kind of understand that it would cause rippling or different lumps of scar tissue underneath the skin. And that can kind of lead to that rippling effect that you see on the top of her leg. Other patients can develop what we call plate like sclerosis. So, sclerosis is just another fancy medical term for thickening of tissue. And in this case, it's the skin. So, the skin becomes a darker color and it becomes thicker and feels different. And you can visually see where the arrow is pointing that she has some parts of her leg that are a lighter color, but then this darker color. And if you were to run your hand over it, it kind of feels thicker and it's smoother than the other parts of the skin and maybe not as mobile. There's also another textbook term that is used called orange peel skin. So, just like here, we talked about that saran wrap around the muscle becoming fibrotic and thick, you will see here those lumps and bumps. And they just have termed this, it's a very old term called orange peel skin, where just like the surface of an orange peel is kind of dimpled, we can also see that in the skin of patients who have EF due to that long term inflammation. Now, if you have EF or a loved one of yours has EF, you may have noticed that in your visits with doctors, they will ask you to put your arms up like this. This is because they're looking for something called groove sign. So, what they have found is when you put your arms up and then the skin kind of sags due to gravity, that fibrosis of the fascia around the muscle will sometimes follow the line of a vein in the body. And so sometimes the doctor can clearly see this outline of a vein coursing through, and the fibrotic tissue is kind of following along. And that's called a groove sign. So that may have been why a doctor in the past had asked you to do some maneuvers during a physical exam. And it's very important that when you see your doctor for the first time, especially, you change into a medical gown so that they can really look at all of your skin, because there's areas you may not have noticed or you don't see on a regular basis, like your lower back, that could have some changes that could give us a clue as to what's causing the elevated eosinophils. So, when we make a diagnosis really of any autoimmune disease, but I'm going to use EF as my example here, it's never just one and done where we look at the skin, we make a diagnosis, we start treatment. It is a methodical approach to building a case to come to a diagnosis. And this is really that frustrating part of being a patient where your doctors are trying to collect data and narrow down the list of conditions they think that you might have, and it's a waiting game as you go through all of these different procedures. But this is really how physicians approach rare diseases, is that we have to get a lot of data in order to be comfortable that we have the correct diagnosis, and that takes a lot of time. So in addition to the skin changes we just talked about, the elevated eosinophils in the blood, which, going back to those first slides that I showed, this is that breakdown, that complete blood cell count. So white blood cells, red blood cells, and platelets. And then this is a screenshot which shows you the breakdown of those white blood cells into different types of white blood cells. And in this case, the eosinophils are elevated. And in the general population, eosinophils, as you can see here, the reference value should be either absent or very low. Another thing we can see is that as that saran wrap around the muscle, the fascia, becomes inflamed and irritated, the muscles right underneath it, I mean, they are stuck right onto each other. So you can imagine that if the saran wrap is inflamed, it's easy to think that the muscles themselves can also get irritated. And this can lead to the muscles breaking down a little bit and releasing enzymes into the blood. And so one of those enzymes is called autolase, or CK, or creatine kinase. So your providers may be checking blood work to look for any muscle irritation that could be occurring. And so that's where the term autolase comes from, is it's enzymes released by irritated muscles. Another way that we can assess that saran wrap lining is MRI. And as you can see here, this is the humerus, so this is bone right in the middle. This dark area around, this is the muscle. But then this bright white area here is the fascia, or the saran wrap around the muscle. And it's very irritated and angry because it's being infiltrated by eosinophils. And it is inflamed and it's thickening and it's just very angry. And that's why it's a different color. So sometimes we will use MRI in order to show objective evidence that there is inflammation, not in the muscle specifically, but in that lining of the muscle. And that is key when it comes to eosinophilic fasciitis, because it's inflammation of the fascia. And then lastly, after we do the MRI, in certain cases, we may request a biopsy, a deep muscle biopsy, in order to get both the muscle itself and the fascial lining. And so here, a radiologist, a doctor who specializes in imaging, is reading the MRI. And they're saying, I think this would be a great spot for a biopsy, because you're likely to get a diagnosis, whether it's EF or not, by taking a biopsy of this area. So if you look here to the right, this is magnified 100 times, and a pathologist, a doctor who specializes in tissue and reading tissue, is looking under a microscope. And the red and pink here, this is muscle. But look at all these purple cells. These are angry eosinophils that are infiltrating the lining of the muscle, the fascia, and they are causing inflammation and pain and sometimes swelling in certain cases. So and everybody's approach is going to be different and how they diagnose EF, but this is kind of a classic approach. And you can see that with each step, we are building more and more data that this is EF. And we'll talk a little bit later, but the average EF patient, it takes 11 months to make the right diagnosis. So there is a lot of trial and error, seeing different specialists, getting the wrong diagnosis. And 80% of cases, EF patients get the wrong first diagnosis. And that's not because your doctors are incapable. This is a very, very rare condition. And other diagnoses and conditions are way more likely than this. And so it's this medical journey of ruling things in and out and getting the right specialists who have seen some of these cases to make the right diagnosis. So to drive that home, I made a little graphic here, and this may resonate with some of you guys. But this is a typical experience. When I see patients, they typically have seen 5 other doctors, and I go through all of their records and I'm reading everything, and it puts together this type of story. So you go get blood work done, whether it's routine or you're just not feeling well, and maybe the primary care doctor says, "Oh, your eosinophils are elevated. That's weird. Have you ever had a parasitic infection, or have you ever traveled to sub-Saharan Africa?" And then they'll say, "Okay, I need you to go see an infectious disease doctor because these are the doctors who know the questions to ask you and they know the testing to do." So you see infectious disease and they're like, "You don't have a parasite. That's not what's going on here. Go back to your primary care doctor." And your primary care doctor is like the quarterback in all of this. So they say, "Okay, I wonder if this is potentially cancer." And they ask you, have you been having fevers? Are you sweating a lot at nighttime? Have you been losing weight and not meaning to? Then they'll refer you to a cancer doctor or a hematologist oncologist. And then they may or may not recommend a bone marrow biopsy because, like we said at the beginning, those eosinophils are originating from the bone marrow. And so this cancer doctor is thinking, okay, I need to evaluate the bone marrow to make sure I'm not missing the underlying cancer that's originating in the bone marrow and then is now causing elevated eosinophils in the blood work that we're seeing. So you do, in some cases, if the cancer doctor thinks it's appropriate, you can get a bone marrow biopsy. This is typically done in a clinic. They'll use local anesthesia, and then they will do a biopsy in clinic. It's then sent to a pathologist, just like we talked about with the muscle biopsy, and they will say yes or no, we see cancerous cells. But in this case, you don't have cancer. So then you go back to the PCP and they say, okay, right, we've ruled out all these other things that are relatively more common. How about we look for an autoimmune condition? And that's where I come into play is you are referred to a rheumatologist, so a specialist in autoimmune conditions. And we kind of go through that workup that I just showed on the prior slide. I'm getting labs, I'm getting MRIs, I'm getting biopsies, and then I'm led to the diagnosis. And I put diagnosis in quote because this is a very linear pathway when the reality is most people are going like this for 11 months and going through a lot of different doctors. And sometimes the diagnosis is EF, and sometimes it's something different, which, APFED understands there's so many eosinophilic disorders that sometimes it can be a vasculitis like EGPA, which I also see quite a bit of, and other times it's EF. And so it's really just about getting your multidisciplinary team of all these really intelligent doctors who all have different skill sets and then doing all of the workup and then hopefully coming to a conclusion. But this is a very simplified version of what it's like to live that process. So let's say that you have a diagnosis of EF or someone you love has a diagnosis of EF. So how do we approach and treat EF? And I put immunosuppression in the middle because, I am a medical doctor. I practice Western medicine. My approach to autoimmune conditions is going to be suppressing the immune system to decrease the inflammation, to decrease the long-term side effects of having uncontrolled inflammation, which can lead to contractures or, more skin changes, a lot of pain and discomfort. So immunosuppression is really always going to be the first thing I'm reaching for because I want to get you more comfortable. I want to prevent downstream complications. But you are a person and you exist outside of just this diagnosis of EF. You have a whole life outside of this diagnosis of EF. So it's important for medical professionals to approach your entire health in the context of EF. So, one thing I like to focus on is bone health. And patients who have autoimmune conditions, including EF, that long term inflammation can actually decrease the strength of the bones. So, if you've heard the terms osteopenia or osteoporosis, that's weakening of the bones and increased risk for a fracture. So, the general population, we're thinking, oh, postmenopausal women, men who are after 50 years. But in patients with autoimmune disease, especially those have been exposed to long-term steroids, which a lot of our patients have been, that can compromise the strength of the bones. So, you may get weaker bones at a younger age than the general population. So, what can I do? Doing strength training. So, that means walking, lifting weights, anything that puts kind of stress and pressure on your bones allows them to strengthen. And then also vitamin D and calcium, making sure that your blood levels of vitamin D and calcium are therapeutic and normal and taking a supplement if needed. In some cases, your doctors may get a bone density scan, which is really an x-ray to look at the health of your bones. And some people may require prescription medications to strengthen their bones and prevent further bone loss and the risk of fracture. We're going to talk about physical and occupational therapy in a later slide, but physical and occupational therapy are an essential aspect of treatment for EF. And it doesn't have to be lifelong, but they will teach you exercises that if you spend 5 to 10 minutes daily doing, it can really allow you to keep to prevent contractures and just keep your joints limber, which can really improve quality of life and your ability to do daily tasks and things that you enjoy. A question I get a lot is, what can I do to be proactive? Following with your doctors consistently. And this is easier said than done. You all are busy people. You may have families, you may have jobs, you may be a caregiver to another person. So obviously, you want to go to your doctor's appointments, but it may not always be the easiest thing, especially if you have 3 or 4 specialists. You have to go get labs and MRIs, you have to take time off of work. It's sometimes as doctors, we forget that you have this whole other life and that you can't just drop everything to do all of our recommendations. So, um, doing telemedicine, I have a slide where we kind of talk about how to optimize and be efficient with your time and medical visits. So, that might be saying, hey, I can't take time off. Can we please do a telemedicine visit so I can talk with you and touch base, but I don't have to find childcare or I don't have to take time off of work? So, we'll talk a little bit about that more later. Mental health is a huge aspect. We're going to talk about sleep, nourishing your body, moving your body a little bit later. But all those things are so critical because with a rare condition, you can feel very isolated. And finding your community like APFED here, coming to conferences like this or going to other conferences in person or participating in research, sometimes that can allow you to find people who understand you more than your doctors can, who don't live with your condition. And it allows sometimes your caregivers to meet other caregivers and they can just talk to each other and find someone who understands what it's like to live the life that you do on a daily basis. Um, Work and life accommodations. So these are just some ideas. If you feel like things like getting a handicap placard or asking for short or long-term disability, if you are having to undergo a lot of diagnostic testing and you need time away from work, you can ask your providers to fill out forms that your HR, your human resources division can provide to say, hey, this patient needs time off in order to work up this diagnosis. Please give them this amount of time off. Or if you don't need time off of work, having work accommodations, which is things like, half a day a week I need off for extra rest, or I need 1 day off a month to go to my doctor's appointments to get labs done, to get imaging done. Just being honest and communicating with your medical team, with your work. Hey, I need more support in this area. I need more time in this area. And this may be easier for other people. Every job is different, but at least advocating for yourself in this aspect of your life may make things a little bit easier. And then we're also going to talk about nourishing your body and kind of dietary, because I get asked about that a lot. And then last, one of the most preventative things you can do is getting all of your vaccinations. I just had my COVID booster and flu shot last week. Everything I recommend for my patients, I do for myself. So getting vaccinations to prevent viral infections is so, so critical because when you're on immunosuppression, when you have an autoimmune disease, if you were to get infected with something like COVID or the flu, your risk of complications is going to be higher than the general population. And everyone around you may not be getting vaccinated or they may not practice masking or washing their hands. So, doing everything you can to be proactive, which means following regularly with your doctors and also getting all of your vaccinations. This is in addition to COVID and flu. Those are just at the top of my mind because we're in that season right now. In North Carolina, we're having really high levels of both. So I've been talking with my patients a lot about it. But pneumonia, shingles, RSV, HPV, there's so many different vaccinations that can provide you so much protection. So talk with your doctors about vaccinations. Insurance gets a little tricky if you're less than 65. Your doctor may need to code the vaccination with, immunosuppressed status or on an immunosuppressive medication in order for insurance to cover it. But it certainly is something that would keep you safer and prevent hospitalizations and in some cases prevent death. All right. So how do your doctors approach treatment? And I'm talking about immunosuppression now. So there's a joke that rheumatologists love steroids, and We love steroids and we love it for a lot of different reasons. It works quickly. It works in almost everybody who has an autoimmune condition, but it's not a good long-term solution. And so it's great to get you more comfortable, but really the end goal is to get you off the steroids and onto a better regimen that has safer long-term side effects. So here's a list of some second line therapies. So your doctors may start steroids first, but at the same time start something that's going to be the long-term solution. And that may be something like methotrexate or mycophenolate. These are the generic names. So you may have a trade name that you call it, and that may be why you don't see it here. But we may start with something like methotrexate in a lot of cases. And then some patients, let's say you keep flaring, you don't feel better, despite taking the maximum dose of one of these medications, you may require a biologic medication. So something like Nucala or Fasenra, which are relatively newer medicines, you may require a combination of these two therapies in order to get off of prednisone. Every provider's approach is different because there's such little data and research in EF that there's not a standard algorithm to treat. A lot of our decisions, I will be honest with you, are made by insurance, what they will approve, but then also the side effect profile. So methotrexate is a relatively inexpensive medication. It has been shown to be effective in EF. So we typically start here because these medications, they're more expensive. They have certain complications. They may be injectables or infusions. So they may not be as convenient for you to take time off of work, or maybe you don't like needles, you don't like injections. So there's a lot of different reasons why providers choose other things. Some people may just require multiple medicines. Some people may require one medicine. Everybody is different, but it's just important that you track your disease activity and you're like, listen, I've been doing this medicine for 3 to 6 months. I'm still having flares. Can we please talk about what the next steps could be? Should I add this medicine? Should I switch medications? And that's really a good conversation to have with your rheumatologist, who is typically driving these treatment decisions. These are some more experimental medications where there have been a few cases that people have published and said, hey, I used this medicine, it worked for my patient. I wonder if it would work for you. So I put them on here, JAK inhibitors and IVIG. You may have used them before. They are JAK inhibitors are relatively newer medications as well, but you may have other conditions like diabetes or blood clots and heart disease. So your doctor may make decisions based off of your other medical conditions, because we don't want to fix one thing and cause an issue with another. So this is a very personalized regimen, and there's very little data on this is the best algorithm for patients with EF. So it's really just up to what your rheumatologist recommends. So let's go back to this graphic, which is what we started with. And it's kind of helpful sometimes to understand how medications work and why your doctors are prescribing certain medications. So prednisone wipes out eosinophils. If I see a patient and they've had high eosinophils in the past and they're on prednisone, 99% of the time when I check their blood work and I'm looking at that breakdown, their eosinophils are absent because that prednisone is driving them out. They are suppressing them. So the idea is, if we stop the production of eosinophils, we stop that inflammation as they infiltrate into the fascia. So this is a lower, like, downstream effect, is that prednisone is wiping those eosinophils out. But what about the other medicines? So these, which is kind of like some of the second line therapies that I listed here, they are wiping out these cells here. These are like lymphoid cells, which are B cells and T cells, but then also all these pre-white cells. So further upstream, they are stopping the production of these cells to prevent the production of eosinophils, to prevent that infiltration, to then prevent that inflammation. So it's really a further upstream effect. And you will notice that we get blood work, like I'll take methotrexate, for example. We get blood work every 3 months because methotrexate is kind of just suppressing a lot of things. So it can affect these other cells down here. And we want to make sure that it's suppressing the correct cell, but we are not causing these other cells to become low as well. And so that's why we constantly are checking your bone marrow numbers and your kidney and your liver. We just want to make sure that you're not experiencing toxicity side effects, because these medications are great, but we are artificially suppressing your immune system. So we want to make sure that we are not creating more problems or more side effects. Now, some patients may be on rituximab. I put that down here because rituximab is very specific for lymphoid stem cells, for B cells. So this is in the same pathway, but it's just very specific for lymphoid stem cells. And it's an infusion that you get every 6 months typically. So it just may work for better patients. Let's say you tried two of these meds and they did not work. So in some cases, physicians may decide to move towards rituximab. And that idea is, again, to suppress further upstream to stop this downstream inflammation. Now, some of these newer medicines that I talked about, this is the exact same graphic, but I removed the old medications and I put in these new little markers. So these are kind of like cell communicators, and they are kind of telling the white blood cells, hey, there's inflammation here. There's inflammation. You got to produce more cells and attack more of the fascia because there's something going on here. And this is where the immune system is malfunctioning and your body is not recognizing itself. They think there's some type of foreign invader. And so they are just sending off all these signals to cause more and more inflammation. So one way that we will suppress these inflammatory cell communicators is through Fasenra and Nucala. So these are interleukin inhibitors. So that's what IL stands for. And there's dozens of interleukins. But in the cases of EF, we feel that IL-5, interleukin 5 and interleukin 4 seem to drive a lot of the disease process in EF. You may have also heard of Dupixent. So this is an interleukin 4 inhibitor. So you can see that these are very similar drugs, but they target different cell communicators. And that might be why, let's say you tried Nucala and it didn't work. So your provider said, okay, let's try Dupixent. What's important to keep in mind is there are no clinical trials head-to-head comparing these medications in EF specifically. So you're never going to find data that's like, this is exactly what we should do. It's all trial and error, and your body may respond differently than another person's body with the exact same condition, EF. TNF is just like interleukin 4 and 5. It is a cell communicator. There's a lot of TNF inhibitors, and you may have heard that term before. There's a lot of them. I have them all listed here. I put some generic and some trade names, and they're up here just trying to suppress those cell communicators at a different part of the pathway. But you can see here, in this, I don't expect you to remember all of this or absorb all of it, but if you see your medicine on here, just trying to understand where it fits in that pathway of disease for EF can help you to understand, oh, this is how this medicine is working, and this is why it's making me feel better. Or this is why my provider chose a different type of medication after this medication did not work. I reached out, we have an autoimmune dermatologist at Duke, and I said, hey, do you ever use ultraviolet or phototherapy for patients who may have the rippling and the plaques? And she said, there's some data on it. We really don't use it in clinic. We typically are using oral or injectable medications, the ones that I just went over, in order to soften up the skin and prevent more fibrosis of both the skin and that fascia around the muscle. We do not have enough data that something like a bone marrow transplant would be helpful in patients with EF, and so it is not recommended. And then in some cases, people will get contracted. So you can imagine if the lining of the muscle is getting fibrotic and there's so much scar tissue, the muscles can contract and it can cause people to have contractions of, let's say, their knees or their elbows or their hips. And that's where that physical therapy really comes into play. But in some really extreme cases, there may be some releasing of tendons, especially if quality of life is compromised. This is never the goal. We are always trying to prevent this with medication, but in some cases it's not preventable. So some patients may undergo surgery. This would likely be with orthopedic surgery or general surgery in order to release some of these tendons to give people a little bit more mobility. But it's not the same as medications and physical therapy. It's more of a definitive cutting of the tendon, and as opposed to making it more flexible. So let's round out with challenges. So, and you all know this better than I do. I just see it from the doctor's perspective and observing this when I talk with patients and hear their journeys. Getting diagnosed is a challenge in and of itself. And I can't imagine the internal turmoil, the anxiety that so much of this may cause. And this has really become something we've labeled as medical trauma. Whereas you've been to so many doctors, maybe your symptoms were disregarded. Maybe you were told that it wasn't real, or you were making this up, or you were faking this. We see that in these conditions because they're so rare that sometimes when medical professionals can't make the diagnosis, they may get a little flustered and conflicted and may say, well, we don't know what this is, so it must not be real. And in rare diseases, that can happen. It's so unfortunate. But there's really a lot of trauma around just getting the right diagnosis. And as I said before, 80% of people with EF get the wrong diagnosis first. And then it can take up to a year to get the right diagnosis. And what I have found is in all of this trauma that's occurring, it all falls back onto you, the patient, and your family and your caregivers. And it's not fair. It's just the reality of the US healthcare system. So, what are things that we can do to address that? What I would recommend is when you're meeting a doctor for the first time, creating a very brief summary of your medical journey so far. I've seen these doctors. They've ruled out these conditions. This is why I'm here to see you because we are worried about X, Y, and Z. I've had patients who mean well, but they bring me boxes. One time someone came in with boxes in a wheelchair. It was like 4 boxes of records. And I just can't go. I cannot go through all of that. And so sometimes, in order to bring your doctor up to date, you can have a typed out, it can be on your phone, but just hey, this is what I've been through. And you don't have to give them every single thing. Just kind of give them a 5-minute overview, which can be really hard, but it will bring them up to date and really make your conversation so much more efficient. And oftentimes, as doctors, we don't get the records beforehand, even if we ask for them. So, this can be a way to maximize your time face to face with a rheumatologist or another specialist. Having the contact of your other doctors, their name and contact, because what I have found is that oftentimes the patient is having to communicate between all of these doctors, and it's really unfair. You're like this medical liaison. And so saying, hi, Dr. Sims, here's my primary care doctor, and here's my infectious disease doctor, and here is their phone number. Would you please reach out to them and communicate your recommendations after we talk today? And it's hard for doctors to find time for that. I understand. But in cases that are complex and rare like this is a time where that communication becomes critical to really streamline the diagnosis, especially if you've been kind of, whirling through the medical system for a year at that point or maybe longer. Write out your questions before you go into the appointment because when you get in there and they're using all these big words, it becomes very distracting. It can become very emotional. Write out your questions beforehand. Bring someone you love and trust with you. They can be on the phone, on speakerphone. They can be on. I have FaceTime with people's moms in visits, and they can be present. The patient can be advocated for. We can communicate. So two people at least hear the recommendations, so you don't feel like you have to remember everything that's going on. And then lastly, just having an internal goal for the appointment. I would like to understand why my eosinophils are elevated. And if we don't understand that right now, what are the next steps we're going to do to get an answer? I would like to know what the next steps are because I've been through this a long time. And do I need to get imaging? Do I need to get a bone marrow biopsy? What would you recommend I do right now to be proactive and productive in order to get a better answer for why I've been feeling this way? And then this is a way to kind of maximize your time in a visit to try to decrease your ability to, take off work or get childcare. So trying to combine medical appointments is always, really it's hard to do, but when you call to schedule, say, hey, I have a lung appointment this day. Could the provider please see me on the same day to cut down on my transport time? Asking about telemedicine, yesterday I was in clinic all day. 50% of my patients were telemedicine, and I just talked to them over the computer. And the other thing we do is we do their labs locally. So if my patient lives 4 hours away, I'm like, hey, is there a LabCorp or a Quest that I can fax lab orders to? And you can get them done locally and they'll fax me the results back. That's an option. Having a local provider where you stay connected to the doctor at a big academic center, but they can communicate with your local rheumatologist and they can really help to facilitate lab draws, imaging, seeing other specialists locally. It's really nice to have someone in your own neck of the woods who can also communicate with this doctor at an academic center and get the input and the advice from them, but then they can advocate for you locally and carry things out locally. That's also a nice way to cut down on transport time. And then the last is getting your infusions and your treatment locally. So again, if I have a patient 4 hours away getting rituximab infusions, our center can contract with a local infusion center and just get their infusions done locally. So they're not having to get a hotel room overnight the night before, or if they don't feel well after the infusion, having to drive home 4 hours. So these are just some tangible ways that you can try to ease the burden on yourself when trying to manage a chronic and complex condition, but then balance it with life outside of EF. So, like I mentioned before, physical therapy and occupational therapy are critical, and doing PT and OT in conjunction with medications, immunosuppression, is really in the literature is found to be this great combination to get your best outcomes possible. So here's a picture here of a patient who's super contracted, but with regular physical and occupational therapy, their range of motion and flexibility has drastically improved. And you can meet once with a physical therapist or occupational therapist. They'll give you exercises to do at home, and then you can spend 5 minutes per day doing these exercises in order to stay flexible. Now, another thing that patients will talk about is a lot of fatigue and brain fog and pain. And there's no one way to fix this. And there's a lot of reasons why patients with chronic conditions feel this way. But my approach is this multimodal lifestyle approach. And with the expectation that it's not a linear improvement. You're going to have good days and bad days. So you're going to cycle through, and maybe you wake up and you're like, today is just not my day. But then the next day is better. And having these habits to keep you motivated and help you to cope when you're having a bad day is also so critical. So, how do we do that? Start off with low intensity exercise. There's a study that just came out that walking for 5 minutes per day, 5 to 10 minutes, lowers your blood sugar and lowers your blood pressure. So, don't feel like you have to set aside 20, 30, 50, 60 minutes to be effective. On your lunch break at work, go walk, whether it's inside or outside, whatever works. Just go take a walk, put on a podcast, and just go walking. Put on your favorite music. That can be huge for both mental and physical health. Building good sleeping habits. We're going to talk on the next slide. There's some free apps and also an app you can pay for that helps with sleeping and how to optimize your sleep time. Managing stressors. This can be getting those work accommodations. This can be mindfulness and meditation. When you can't fix your external stressors, trying to change how you interpret them and how you internalize them can be one of the biggest ways that you can create space against that stress in your daily life. And then leaning on your network of friends and family and organizations like APFED, like just being here is a part of your support system. So here are some free resources that they all tackle different things on how you can address fatigue and brain fog and pain in patients who have chronic conditions. The Curable app is not free, it's $6 a month, but it gives you approaches, non medication approaches to dealing with chronic pain on a daily basis. And this is a mindfulness approach. And you can use this in combination with other things. So for me, my coping mechanism is I intellectualize everything. So sometimes reading a book about what I'm experiencing mentally helps me to break it down and understand why I'm having the thought pattern that I am and how to address that. And then other patients may require medications. So you've done all the things, or doing medications with all of these other apps and exercises is a great combination to get a lot of relief from brain fog, fatigue, and pain. Now, what about nourishing your body? I get this question on a weekly basis. Is there an anti-inflammatory diet? The answer is the data is very poor in autoimmune conditions, but there is a rheumatologist at my institution who studies arthritis, inflammatory autoimmune arthritis, and diet. And what they have found is things that you probably already know. So, less processed food, less added sugar foods, more plants, more Mediterranean style diets. And I have some examples here. So, this is things like eating out less, eating more at home, portions of more fruits and vegetables, less of highly processed foods, less deep fried foods, less sugary foods like cakes and candies, those kinds of things. And again, it's starting slow and really incorporating these things over time. There's really not data that any specific supplement over the counter is anti inflammatory, but there are three that I have listed here that do have some legitimate data. turmeric, which you can either cook with or take supplements of, and dried ginger, or you can drink ginger tea. So, what I would recommend is talking with your doctors before you do or start anything because sometimes supplements are not regulated by the FDA. Actually, often they are not regulated by the FDA. So, you want to make sure that you are not going to take anything that could compromise your prescription medicines or could create more issues for you in the long term. And lastly, this is a website from UCSF talking more about anti inflammatory diets for patients with autoimmune conditions. And what are some changes you can make that may make you feel better overall, mentally, physically, but also from an inflammatory perspective? And then lastly, what can you do to move your body? I like to use this term more than exercise. Start slow and ramp up. So 5 to 10 minutes per day. Do something you like. That's the best exercise. If you're not going to do it consistently, it's not a good fit for you. So if that's walking, walking is underestimated. Walking, biking, swimming, stretching, yoga, all of those things. You can find YouTube videos for free of yoga at home, sitting yoga where you don't have to get up and, flip around or do anything too intense. Start slow, but just enjoy moving your body. And then this is my last slide. I just want to make sure we have enough time for questions. How do you work in a healthy lifestyle into what you're already doing? Because adding another thing can be so stressful. So if you're watching TV, I have a walking pad that I will walk on while I watch TV. You can stand instead of sit. Decreasing your sitting time is critical. Taking the stairs instead of the elevator, parking further away to kind of motivate yourself to get in more steps. And then if you have a step counter, trying to have a step goal per day. So something like 6,000 steps per day is helpful. And then these are just additional resources on how to work in moving your body in a daily basis for a patient with a chronic condition. So I'm going to stop there and stop sharing my screen. And I'm happy to answer any questions.
Wonderful. Thank you for such a wonderful presentation and all the details and analogies to help people understand how it relates to their life.
Thank you.
Alrighty, we've got some wonderful questions coming in. For those of you that have not seen it yet, please click on that Q&A tool across the bottom of the Zoom screen. You can type in your question there, and Dr. Sims and I are going to have a conversation. Alrighty, so the first question that came in, how does eosinophilic fasciitis affect pregnancy outcomes? And is it possible to have an uncomplicated pregnancy with this condition?
I love that question. That is my specialty is high risk pregnancies in women who have autoimmune conditions. So what I would say is we have limited data specifically for EF, but we do have data in a lot of other autoimmune conditions, and something closer to EF would be like EGPA, which is an eosinophilic vasculitis. Our patients actually do very well. So the patients that are highest risk are those who have unplanned pregnancies and who are not on pregnancy compatible medications. So what I would recommend first step would be go to all your doctors and say, "Hey, I am interested. This is my pregnancy timeline. I would like to get pregnant in the next year. Do we need to make medication changes so that I can take pregnancy compatible meds that I can continue throughout pregnancy and breastfeeding so that my disease can stay well controlled?" What we have found is that women who have planned pregnancies and stay on their meds have a much lower risk of flaring during pregnancy. There's always the risk of flare because of the hormonal shifts in pregnancy, but patients do extraordinarily well. And the last thing I will add is the patients who do the best are those who have no what we call end organ damage. So this can mean that they have heart failure, they have respiratory failure or lung failure. Those are really the highest risk patients, or maybe they're on dialysis and have kidney failure. Those are patients that we say, okay, let's talk about the risks of pregnancy in your case. But if all your organs are functioning normally and you don't have any issues with kidney failure, heart failure, or lung failure, most of those patients do extraordinarily well. So I am very hopeful for a lot of patients, especially with EF, that they would do very well in pregnancy.
Certainly came to the right person for that question then. Alrighty, so next up, can EF be hereditary? They have someone that was diagnosed several years ago, and now their daughter was diagnosed. So they're curious the connection.
That is a great question. And it kind of goes back to why do I have an autoimmune disease? So there's a difference between genetic and hereditary. So what we have found in certain cases is that there is a genetic link and a genetic cause for autoimmune conditions, but not all genetic causes are necessarily hereditary. But what's so hard about autoimmune diseases is we can't say there's a 25% chance that your child will have EF or your child will have this condition. There's certain cases of, like, let's say, trying to think of a good example, like ALS or multiple sclerosis, where they can say, or Down syndrome, where they can say, there's this percentage chance that your child is going to have this condition if you were to have another child. And in autoimmune diseases, we cannot say that. But what I will say is, whenever I meet a patient and they have a family history of autoimmune diseases, my spidey senses do go up, and I have a higher suspicion that you potentially have a genetic cause for your autoimmune condition. So the short answer is it is very likely there is a genetic condition or a genetic link. We have not identified that yet. So we cannot give, like for the pregnancy question, I couldn't give that person a percentage risk that their child would have EF. But it is important to tell your doctors that, hey, my mom has EF. And so I'm really concerned that I have it too. And really getting a rheumatologist to get eyes on you earlier to say, we are or are not concerned that these symptoms are related to the same condition that your mother has.
Thank you. Alrighty, next up is a question about contractures. Once you have them, are they permanent regardless of stretching exercises?
That is a great question. In certain cases, they can be. So, contractures certainly have a continuum. So, there will be early contractures and then later contractures. And that's really based off of the angle of the contracture. So, somebody who's like, listen, I can only straighten my arm to here. This is a less severe case than someone who is truly entirely contracted. So, it depends on a few things. It depends on how severe the contractions are and how long they've been going on for. So, traditionally, contractures take several months at least to start forming. It's very rare that somebody wakes up in one day and they have contractures. Normally it's like, oh, I went to go, put my shirt on and I noticed that I couldn't stretch my arm out all the way. And so catching those contractions early on like that and talking to your doctor, because progression of contractures can indicate that you need more aggressive therapy, potentially, not always, but potentially. So you, in that case, I would say go to your rheumatologist and say, listen, I think I need more aggressive therapy because I'm developing contractures and I'm concerned that what we're on right now is not preventing the progression of my disease. The other thing is getting that physical therapy on board early and doing it on a daily basis and consistently. Because the thing about contractures is it's something you're going to have to be fighting all the time. You're going to have to constantly be staying limber with those exercises, and it's not something entirely that can be addressed by medications. It's going to be a combination of medicine and physical therapy. So the answer is there are some cases where contractures are going to be irreversible. And that's really where that surgery aspect comes into play that I mentioned. It's not ideal, but if your rheumatologist feels that they have optimized your medical regimen and that is fibrotic tissue that is irreversibly scarred and no medication can reverse it, then that would be a case for surgery.
Thank you. So, some people have some questions about remission. Is it possible to get to the point of remission? How long does treatment take to get to that point? So, what can you tell us about the potential for remission?
That's a great question. And I just had a conversation with a patient with a different condition a few weeks ago. And she said, one of my doctors told me I was in remission, but I'm on medication. So I think the first thing is defining what remission means to everybody. Because for this patient specifically, she thought that remission is disease free on no medicine. And the reality is, most patients with EF are going to require some form of medication to control the inflammation lifelong, at least in my experience, because we don't have definitive curative therapy right now. So, going with the definition of remission as I have a good quality of life, I'm not struggling with pain and swelling on a daily basis, I can do the hobbies I enjoy, I can go to work, but I'm on medication, that is absolutely achievable. And I have two patients right now with EF who have wonderful quality of life and are in what I would consider remission due to they can go travel and work and hike and do what they want to do. And they're not struggling and having to go back on and off prednisone all the time. They're not in and out of the hospital. But if my goal is always to get you off of prednisone and have you on a long-term therapy and prevent hospitalizations and the need for going back up on 60 milligrams of prednisone. So if that's how you're defining remission as good quality of life on a stable medication regimen, it is absolutely possible in EF.
Thank you. So, kind of dovetailing off of that, people are curious, how do you know which symptoms are permanent and which might still be improved? And at what point are there concerns that other organs might get involved?
Yeah. Knowing when something is permanent versus not is likely going back to that slide I had where we're like collecting all of the data. And so this is likely blood work, imaging, in some cases, biopsy. And this can be reassessment of disease activity as opposed to a new diagnosis. So we know what the diagnosis is, but we're having to use all of these different diagnostic tools to decide, is there active inflammation or is this all just scar tissue? And so a repeat muscle biopsy may help your rheumatologist understand, oh, there is some remaining inflammation in the fascia of the muscles, and we need to be more aggressive with therapy. Or they may say, listen, it just shows all scar tissue, and this is not reversible. They may also get an MRI of the muscle where they can look at it with the radiologist and say, hey, based off of how bright that fascia is on the MRI, would you say that that's active inflammation or is that scar tissue? So that's a nice non-invasive way with another specialist to kind of decide, is this just permanent scar tissue that even if I gave you the most powerful immunosuppression, even if I, did a bone marrow transplant, there wouldn't be any reversing of what's happened so far. And the reason it's critical to distinguish those two things is what you don't want your rheumatologist to do is blast you with higher risk, more medications with more toxic side effects, and you not get any benefit from it because this is all scar tissue. So there's a few approaches, like I mentioned, there's the MRI, there's the repeat biopsy. The other would be clinical symptoms. So if you're like, hey, I'm developing more plaques, or my contractions are getting worse. In some cases, your rheumatologist may say, okay, I'm concerned that your disease is still active and progressive, and this is reversible. So we need to be more aggressive with therapy. So for each patient, it's just different. And the other thing is getting physical therapists involved. So physical therapists go to school for a very long time. One of my roommates in med school was a PhD physical therapist. She spent 4 years in physical therapy school. So these are true experts. So I would also be picking up the phone and calling the physical therapist and saying, based off of their range of motion and the flexibility of their tendons, do you think that they have any ability to recover more range of motion, or do you think that this is a permanent contracture? And the physical therapist and occupational therapist would be more qualified to answer that question than just myself. So it would likely be talking with a whole team.
Thank you. So, another question that's repeatedly coming up is questions about the correlation between eosinophil levels and symptoms. In
Mm.
some cases, people are seeing that their eosinophil count is going down, but they're still seeing symptoms, and they'd like to learn more about kind of that correlation.
Yeah, that is a really frustrating experience for a lot of patients with autoimmune disease. The other thing that people will often say is the doctors will say, oh, your inflammatory markers are normal. So my job's done. Your disease is well controlled on paper. So, and that's really where it comes down to when I talk to my patients, my threshold is what's your quality of life and what are you able to do the things you want to do? And if not, let's talk about it. So, what we have found in other autoimmune diseases as well is that sometimes there is a discordance or opposing outcomes of what we're seeing in the labs versus what we are seeing clinically. So I just saw a patient for hypereosinophilia a few weeks ago, and her eosinophils is completely wiped out. They are normal, but she feels terrible. She feels terrible. And that's because you are getting a blood sample. This is a snapshot of the blood. This is a one-time sample looking at the eosinophil levels. That's not always reflective of what's occurring in the fascia or the muscle itself. These are two different environments. So just because the prednisone has wiped out the eosinophils in the blood, that does not mean that the fascia itself is not inflamed and that you don't currently still have ongoing disease activity. That is why the diagnosis is more than just me looking at labs or me looking at your skin. That's why we're also doing MRIs and other diagnostic imaging, because the blood work is not always reflective of how you feel. And we've seen this in other autoimmune diseases. So, eosinophilic vasculitis, sometimes their lab values will turn negative. Certain antibody markers will turn negative, but they still do not feel good. And the data we have is more robust for eosinophilic vasculitis. And they have found that even if those antibodies turn negative, it's not always predictive that that patient is in quote unquote remission or that patient is well controlled. It's just that that antibody has turned negative, and that is not in concordance with the symptoms of the patient or the disease activity. So the bottom line is that just because the eosinophils in the blood are gone and we've kind of suppressed it with immunosuppression doesn't mean that downstream the eosinophils that have already invaded the fascia are not still active. So you're not crazy. Those are two different metrics of disease activity. And it may be worth talking with your rheumatologist. My hope is that they would listen to you so that they could maybe get a muscle MRI and say, okay, your eosinophils are gone in the blood, but we still see some active inflammation in the fascia. So they're not always going to be showing the same thing when it comes to disease activity.
Thank you. We also have some questions about what kind of special considerations need to happen for juvenile patients.
Oh, that's a great question. So I will give the caveat, I'm not a pediatric rheumatologist, and I am very spoiled because we have a really strong and huge pediatric program. And so I'll be honest with you, in these cases, I'm typically picking up the phone and calling my pediatric colleagues. But one thing that is very critical is this condition is lifelong. Like I was saying before, we don't have a cure right now. So if a patient gets diagnosed younger, there's going to be more time and more years for complications to occur with things like contractures are really the big thing that's coming to my mind. And the skin involvement as well. So my first recommendation would be to have a true pediatric rheumatologist. They go through different training than adult rheumatologists do. They look for different things, and there are different eosinophilic and there's different autoimmune conditions that they see in the pediatric population that we do not see in the adult population. So when I have a younger patient and I call pediatrics, they'll say, oh, have you thought about these 10 diseases that we see in patients when they're much younger? And I haven't, because that's not my skill set and I don't see pediatric patients. So that would be the first thing, is make sure you have a pediatric rheumatologist who is well versed in working up hypereosinophilia and managing EF in a young patient, but getting that physical and occupational therapy early and helping the young patient to incorporate these lifestyle changes early is going to be a huge part of maintaining quality of life. And what we have seen in some of our younger lupus patients is they go to college and it's not cool to take medications. It's not cool to care about your chronic condition. Nobody else has it, and nobody else has to do all of this extra stuff that I have to do. Kind of like type 1 diabetes, having an insulin pump and just trying to normalize that everybody has health conditions, and some are more obvious than others. So there's a big mental component, and we see a lot of issues with medication adherence in younger patients because they're just younger and they want to go live their life and be free, and sadly they don't have that flexibility and freedom that a child without EF has. So oftentimes having a life coach or a pediatric colleague that's explaining to them the benefits of long-term medication adherence and physical therapy is going to be critical. But in terms of like organ involvement, at least with my experience in younger patients, I haven't seen that younger patients get different disease manifestations in some of my relatively older patients. So I approach them all the same regardless of their adult age, but my pediatric colleagues may have additional recommendations that I just don't know as an adult provider.
Thank you. Alrighty, I think we've got time for maybe two more questions. Alrighty, so we've got a few questions that are coming in about the color changes that can happen to skin when it gets inflamed. So we're going to kind of combine a couple questions. So some people are seeing that it turns dark. Some people are seeing that it's like a pink blotch. What can you share about how to treat those skin color changes?
Yeah, that was my question for the autoimmune dermatologist when I messaged her. And I was like, would you do medication in addition to phototherapy? And we do phototherapy for things like psoriasis, like big patches of dry skin, which is obviously, it is an autoimmune condition, but a completely different disease process. But she said that the best way to approach those plaques and lesions is starting oral or injectable therapy early on in the disease course. And it kind of gets back to that question of what's reversible and what's not. So just like the contractures are like, this gradual inflammation that over time can get worse without treatment, I think of the skin manifestations very similarly. So there may be earlier lesions like these pinker lesions, but then over time, they may become more fibrotic and darker, kind of like we saw in the pictures, these big dark plaques. And some of that may be reversible with early systemic therapy and injectables and oral medications. But some patients may go on to just develop darker skin where there was inflammation previously that's not reversible. It's different for every person, and we don't have studies to indicate who is going to have more permanent skin manifestations than another person. But the dermatologist told me that early and aggressive therapy is a way to try to prevent more plaques from forming and more of that hyperpigmentation from forming. But once it hits a certain point, it may not be reversible with medication. But you could certainly ask for phototherapy in addition to systemic medication if you feel like you would like to try that, just to be as aggressive as possible with the plaques.
Thank you. Alrighty. Well, for our final question here, what is the likelihood of connecting other eosinophilic conditions when someone has eosinophilic fasciitis?
Oh, sorry, can you repeat that?
How likely are you to develop another eosinophilic condition
Oh, okay.
if you already have eosinophilic fasciitis, or vice versa? If you have eosinophilic esophagitis, does it make you more likely to develop eosinophilic fasciitis?
That's a great question. It certainly can. So I will give the example of eosinophilic vasculitis. So oftentimes those patients can have early onset, or they can have asthma that comes on in adulthood. That's like a huge red flag, and that's an eosinophilic driven process. So yes, I will say clinically, I have not seen eosinophilic fasciitis overlap with another eosinophilic disorder like esophagitis or is eosinophilic vasculitis. Often what happens is I think that they have eosinophilic vasculitis, and then through my workup I find out that it's actually eosinophilic fasciitis. So the answer is yes, there is a higher risk, because if you think of those eosinophils as being overproduced, they can go a lot of different pathways. And so maybe they choose to infiltrate the fascia in some patients, but then in other patients they can infiltrate the heart. Especially in eosinophilic vasculitis, they can cause gastrointestinal issues, cardiac issues, brain issues. So it is certainly possible. But I will also say that in your workup, at least in your initial diagnostic workup, those other overlapping conditions should be on your doctor's list of diseases, and we're kind of checking them off as we go and taking them off the list. So at least you get the right diagnosis in the beginning, which most people don't. But your doctor should always have a suspicion for other eosinophilic driven conditions. Like you may be higher risk of getting esophagitis or asthma because we know that you have an eosinophilic disorder in the first place. So there is a risk. The other silver lining a little bit is that if you were to develop another eosinophilic driven autoimmune condition like an eosinophilic vasculitis, the treatment between the two is very, very similar. So methotrexate is something we can use for EF, but it's also something we can use for eosinophilic vasculitis as well. So the hope would be that we could combine therapies to treat multiple different conditions. But again, I have not seen that clinically, but I do believe it's reasonable that you would be higher risk for another eosinophilic condition.
Well, thank you so much for all your time today to be able to help educate our patients and caregivers about eosinophilic fasciitis, and also for staying on through so many questions. We know we didn't get through everyone's questions today, so we will go through them and work to identify other times to be able to help follow up with each of you that were on this webinar today to help get additional questions answered. Alrighty. Well, I also want to make sure we take a moment to thank our education partners for supporting this webinar series and helping make this possible. That includes AstraZeneca, Bristol Myers Squibb, GSK, Sanofi, Regeneron, and Takeda. To continue learning more about eosinophil-associated diseases, we encourage you to consider subscribing and listening to our podcast, Real Talk Eosinophilic Diseases. In the latest episode, we talked with 3 high school students about their science fair project that helped raise awareness of EOE. And if you look further back in our record of episodes, you'll see that Dr. Sims was on one of our episodes speaking with a patient about their journey together. It's really an impactful episode to listen to. You can find it at apfed.org/podcast, as well as on Apple Podcasts, Spotify, Audible, and more. Another way to continue learning is by registering for our annual patient education conference. Now, you may look at this and say, didn't this already happen? Yes, but here's the really neat thing about EOS Connection. Our annual patient conference, we record each of our sessions to be able to make them available on demand for 6 months after the live events. So these are still available to watch on demand through the end of the year. So I encourage you to go to the URL on the screen, register for free, and watch those sessions. Finally, we encourage you to continue the discussion started today in our online community on the Inspire Network. It's a great place to connect with other patients and caregivers for support. You can check it out at apfed.org/connections. Well, thank you again for joining us today for APFED's EOS support webinar series. I know there are many questions that didn't get answered today. We do have a log of those. And if you have other questions you haven't asked yet, please email mail@apfed.org. Have a great afternoon.
Thank you, Jennifer.
You're welcome. Thank you, Dr. Sims.